Will be a little different from what you have been hearing so far. So to begin, I like to draw all of your attention to two of the newspaper articles which had been published previously. So if you look at the first one, which was published in 2010, it says that there are 9,000 to 10,000 TB patients reported annually, and most of these patients are coming from the Colombo area. And the same issue was discussed again in the next year, which said in 2011, there are about over 10,000 TB patients reported annually. So according to these articles, it says that the TB or tuberculosis has become a health concern in Sri Lanka recently. So the reason I showed these articles is that my talk today is based on TB. So as you all may know, tuberculosis, in shortened form TB, is an infectious disease caused by Mycobacterium tuberculosis, and it's a air-transmitted, airborne disease. And it is considered as the second most deadliest infectious disease in the world. So if you look at the status of TB in the world, there are about 9.4 million new cases of TB reported, and 1.8 million deaths occurring due to TB in the world. And more than 33% of these cases are in Southeast Asia. And TB has also been recognized as a major cause of mortality in complex emergencies. So complex emergency situation where the people are displaced, it can be due to a war or a natural disaster like a flooding or earthquake or so on. So with limited food and clean water, there's a higher chance of spreading the infectious diseases. And in such situations, TB has considered as a major cause of death. So if you look into the status of TB in Sri Lanka, there are about 17,000 people who are having TB currently. However, there are 11,000 new cases reported annually. So according to the WHO data, the percentage of TB incidence has been increasing in the country recently over the last few years. And out of this, 1.4% of TB is MDR TB. MDR TB is a status of TB where the Mycobacterium tuberculosis have developed the resistance for normally given drugs for TB. So these people have to be identified and they have to be treated with special care separately. So what should we do to prevent TB? So we need proper TB control programs, such as we have to be able to detect the people who are suspected to have TB early enough, and they have to be followed with proper treatment before they turn into a status of MDR TB. And also there has to be proper ways to identify the MDR TB cases from the normal ones and treat them separately. But so far it has been difficult to control TB. Why? We are not having a proper diagnosis technique which can detect the TB early enough and accurate enough. So if you look at the current methods of TB diagnosis available in the world, microscopy, culture, nucleic acid amplification methods such as PCR are the currently available methods. But none of these techniques are meeting up the requirements. None of the techniques is able to detect the TB patients early enough and accurate enough, both at the same time. So if you look at each technique very briefly, there are goods and bads. Microscopy is cost effective and rapid, but in sensitivity and specificity wise, it's very low. And it's able to identify the mycobacteria only up to the genus level, but not to the species level. And it's very subjective to the technical officer as well. Therefore, always lead into inaccurate and misdiagnosis. Then culture is considered as a gold standard of TB diagnosis at the moment. It's very specific, accurate, but it takes very long. So by the time the confirmation comes whether the patient to have the TB or not, he must have progressed with the disease for a long time, and it's time consuming. So if you look at PCR, specific and it's relatively rapid, but it's expensive and also need special equipments and laboratory infrastructure. Therefore, it's not suitable for resource-limited settings such as what we find in Sri Lanka. So how do we do the diagnosis in Sri Lanka for TB? There are few places, very few places in Sri Lanka where TB diagnosis is done. And they are also based on the city limits. And most of these places rely on the microscopy. Therefore, only 60 to 80% of the TB cases are getting detected. The culture is done at Velisara mainly, and identifying MDR TB is also done at Velisara Chest Clinic, the main place for the detection of diagnosis of TB. Because of these reasons and limitations in the diagnosis techniques, the TB control has been very difficult in Sri Lanka. So what we need is actually a rapid, sensitive, accurate method with a low cost to diagnose TB. So possible solution emerged recently with the development of a new technique called loop-mediated isothermal amplification technique to detect infectious diseases. So in shortened form, this method is called LAMP. It's a nucleic acid amplification based method, but the results are available within 2 hours. And it's sensitive and specific enough to detect the organism up to the species level. And it doesn't need special equipment, just a water bath is enough. Therefore, well suited for developing countries. And it's more importantly low cost, therefore can be used even as a field test. So with all these concerns and with the development of this new technique, we initiated this study to validate this LAMP technique to diagnose tuberculosis in Sri Lanka. So the objectives of the studies were first to validate this technique to suit local settings using a standard MTB culture H37. Then the second objective was to test MTB positive cultures made from samples collected from patients with the LAMP assay and compare its sensitivity and the specificity with culture technique. So the final goal is to implement this method in local hospitals and chest clinics, even in rural settings. So it's a collaborative project with Dr. Ajit Nagahavatta from University of Ruhuna, Karapitiya, and Dr. Jayanthi Alvitigala from Velisara Chest Clinic, and Dr. John Kenneth from India. So the procedure is very simple. You take aliquot of the sample and heat it for 10 minutes at 100 degrees, and you mix it up with the LAMP reaction mix, which includes primers, deoxynucleotides, and BST polymerase. So the mixture can be incubated for 45 minutes at 65 degrees. And once the incubation is completed, you add a DNA binding dye, which is orange normally. If the amplification with the LAMP assay has happened with the presence of the infectious organism in the sample, the dye will turn to green from orange. So you can do a visual detection by the naked eye. And also this green color is fluorescent, so under UV light you can see the fluorescence. So it's very simple detection. So the whole procedure takes about 2 hours. So I said earlier as well that LAMP is a nucleic acid amplification based method. So what happens is, if the infectious organism is present in the sample, once you add the primers, it will bind to the DNA of that infectious organism, and it will amplify the region of the DNA of that infectious organism denoted within the 2 primers into million copies. And these copies will be interconnected with small DNA loops. That is why it is called loop-mediated amplification method. And this polymerized DNA or this amplified DNA will turn upon binding with the dye to a green color. So in these assays, we used 2 sets of primers. One is called universal primers, and the second is called MTB-specific primers. Universal primers will recognize a region that is common to all the species in Mycobacteria genus. But MTB-specific primers will recognize only a unique region that is found only in Mycobacterium tuberculosis. So if you perform the LAMP assay with universal primers, it will identify Mycobacteria to the genus level. So all the species in Mycobacteria will become positive if present. So if you do the LAMP assay with MTB-specific primers, it will identify specifically Mycobacterium tuberculosis among other species of Mycobacteria genus. Okay. So the results. Objective 1, validating the technique. So we successfully standardized the method with the standard MTB strain H37 for the identification of Mycobacteria genus to the genus level as well as to the species level using the 2 sets of primers. So as you can see in this diagram, the first diagram shows 2 LAMP assays performed with the standard strain, and the negative control contains only water. So as you can see at the end of the LAMP assay, the reaction mixture that contained the standard culture has turned green, whereas the other one remains orange. So it's very simple to detect with the naked eye. And you can, the same tubes have been shown under UV light, where the green fluoresce, you can see as fluorescent. So in the objective 2, we are still performing this objective 2 to test already positive culture samples. So we have used stored Mycobacteria cultures obtained from University of Ruhuna, Department of Microbiology, as well as from Velisara Chest Clinic. All of these samples are confirmed samples to have Mycobacteria, but some of them have been confirmed to the species level as well. Some of them have been identified to be MTB as well, basically. And also we included some of the non-mycobacterial cultures as well to the assay to pick the sensitivity of the assay without the knowledge of the experimenter. And we have so far tested 14 cultures, and our target is about 15. So these are the results so far with those 14 cultures. The first 6 samples were tested with both universal primers and the MTB specific primers. And it became positive with the universal primers, but negative with the specific primers. So the inference of that result is those samples contain just Mycobacteria. Then another sample was tested with both assays, and it became positive for both tests. So that means it has to be Mycobacterium tuberculosis. However, to confirm these results, we have to confirm using the culture technique as well whether these samples are MTB or not. Then 6 other samples, they are confirmed MTB samples using culture technique, but we were able to do the tests only with the universal primers, and they became positive, saying that they are Mycobacteria. And the confirmation of MTB using the LAMP assay as well, we have to perform we have to repeat the experiments with specific primers for the LAMP assay. So the last sample was tested with universal primers, and it became negative for universal primers, and it's a non-mycobacteria. It was confirmed from the culture technique as well to be a non-mycobacteria. So conclusions so far. So we have standardized the technique successfully. It was completed with the H37 MTB standard culture. And based on the results so far, we can say that LAMP successfully identifies Mycobacteria at genus level, because all the samples that we tested are confirmed Mycobacteria samples, and all the samples have given positive results with the LAMP assay as well. So with 100% sensitivity and specificity. Then the sensitivity and specificity of LAMP in identifying MTB at the species level is still at pending. So we are doing some more experiments along that line. So that's all. Thank you very much. This project was funded by Sir John Kotalawala Defence University.